First of all, I'm John from LA Property Department, and I welcome everybody to the History Museum and Archive, and we're very happy to have this exhibition here and to have the people who are going to be speaking in just a minute. And before then, we don't want our panelists to sit up against the wall. We're going to move this forward. First, we're going to have a land acknowledgement from Tom Brody, and then we're going to do a 3-minute performance.
The county went through about a 2-year process working with Native tribes to put a land acknowledgement together, and about 8 months ago they officially released it. So this is the official County of Los Angeles land acknowledgement. County of Los Angeles recognizes that we occupy land originally and still inhabited and cared for by the Tonga, Tataviam, Serrano-Quiche, and Chumash peoples. We honor and pay respect to their elders and descendants, past, present, and emerging, as they continue their stewardship of these lands and waters. We acknowledge that settler colonization resulted in land seizure, disease, subjugation, slavery, relocation, broken promises, genocide, and multi-generational trauma. This acknowledgement demonstrates our responsibility and commitment to truth, healing, and reconciliation, and to elevating the stories, culture, and community of the original inhabitants of Los Angeles County. We are grateful to have the opportunity to live and work on these ancestral lands. We are dedicated to growing and sustaining relationships with Natives, peoples, and local tribal governments.
Everyone close your eyes. When you open your eyes, that is the curtain going up.
In the beginning, we had very little staff. The holy days were terrible. I had to beg people to come in on Christmas. Christmas morning, we had very little staff.
Staff as they walked in, we're screwed. I'm sorry. It's going to be terrible. You're going to have 30 patients, but I'll be there with you. We'll do this together and we'll get through. And they were willing.
As I was putting together the assignments, Dr. Emily walked in with some nurses. And then Dr. Heidi walked in and she brought in some staff, and it brought me to tears. And I felt, this is a Christmas blessing beyond belief.
It was a really good day. Although it was a really bad day. But it was a really good day because they stepped in.
So before we begin, maybe we could just take a moment and everyone can feel their feet on the ground. Yeah, just acknowledging what an impact it can have as we're witnessing, you know, for folks who haven't been here, like the amazing panelists we have to arrive and be inundated in a space that just brings up so much implicit memory. So just inviting everyone to be in this collective moment of grounding, inhaling deeply, holding it at the top, audible exhale. Just looking around and meeting familiar faces or new faces. Awesome. So, hi everyone. Hi. Greetings. So my name's Clancey. It's so nice to be here for this discussion. It's the second conversation we're going to be having. Welcome everyone. Yay, come on in. Yeah, the second conversation we're having tonight amidst a series of panel discussions to continue to learn from and kind of excavate the stories that were, the collective experience of the COVID pandemic, specifically through the lens of the quarantine and isolation sites that put forth by the county. And so there's a lot of lessons learned, as we heard in our first in our first panel, with Jennifer Sodarski was there, as well as Emily Thomas and Marissa Axelrod and Soma Segwell of Skid Row. So many amazing insights about the innovative experience and the challenges and how adversity really led to innovation. So that was a great conversation, and you can all listen to it there's a video on LAPD's website if you want to learn a little bit about what was said there. But tonight, the exhibition, or the panel, I can't speak, the panel is going to be, really we all want to hear from these incredible folks we have up here, their stories, who they are, what they do, and then with this lens, particular focus on lessons learned about housing specifically and permanent supportive housing, and how it was that so many folks were successfully given shelter during the pandemic. And what can we really learn from that time in terms of best practices for transitioning folks into housing, maintaining folks in housing? What does that look like? So it's a really big conversation. I was talking to Jen earlier. I'm overwhelmed by the breadth of that conversation, as well as the breadth of experience and knowledge and diverse backgrounds that each of you all have. So we'll see how we work. But we're going to flow, and I'm going to learn from you. And so the title of this panel is called Housing is Healthcare, Part 1. There's probably there's going to be 500 parts probably, but this is Part 1. And so I wanted to hear from everyone. So we're going to invite each panelist to kind of introduce themselves. And I'd love to hear from you each. What is housing is healthcare, that word, that phrase? What does that mean to you? And how does your kind of professional experience and experience during the pandemic inform that concept for you? So, I can read all of your introductions because they're lengthy and awesome, but it might be nicer to hear from you all. And I would love to start with Heidi. Dr. Heidi, would you please kind of introduce yourself and then orient us to this conversation by speaking a bit about housing is healthcare. What is that?
So it's so great to be with you all and just sharing my emotions. And I'm probably going to keep crying because I'm having some PTSD, which I didn't expect. And I'm sure a lot of us have this kind of feeling when we've been through the trauma. But at the same time, I was sharing with Clancey earlier, it's also from a place of gratitude and humility, because I think we came together in a way that does need to be recreated to deal with the ongoing structural violence that so many of the people we care about face. So I'm the Chief Medical Officer for Housing for Health. It's a program of the Department of Health Services through LA County. And its intent when it was built 10 years ago was to recognize that you really can't have health without housing. That part of being human means having your basic needs met, which is having shelter, food, clothing, feeling secure and safe, feeling that you have a community, that you're integrated in that community to pursue meaning and purpose in your life, And housing is one piece of it, but it's a fundamental piece. Because if you don't have that basic, it's very difficult to, I think, achieve your full potential. And I would say to those of you who have experienced homelessness, it isn't defining. All of us have incredible resilience and strength. And even if we find ourselves without a house in the moment, it doesn't mean that we don't have a home, right? Within ourselves or with the community that we choose to build, or a selected family, and I think that's really critical. And so housing is a piece and structure, but for me, housing, if we think of it globally, is really about supportive structure. And I think every day as I walk down Skid Row or in my own community about how people do what they can to create support and safety. And that as a civil society, we shouldn't even be having a discussion about whether housing is necessary. We do, which is crazy. We should be, an advanced society, be talking about how do we help everyone live to their fullest potential. But we're still regressed evolutionarily. So it's a long-winded answer to your question that it's a fundamental, but it can't be something that defines who we are or where we are going to go.
Thank you so much, Heidi. Yeah, so circling back to much more on that in a moment, but perhaps Angie, if you could introduce yourself, and if you'd like to add to this concept of housing is healthcare as the title of this discussion, what does that mean for you?
Okay, so I'm Angie. Obviously, you said that. But
Hi, Angie.
Hi, Angie. So I'm the supervising clinic nurse for Housing for Health for 3 of our programs, which means I'm in charge of the nurses for inner housing, enriched residential care, and permanent supportive housing. And as far as what I think that, or housing for health, but I know I'm putting it the wrong way, but anyway, it's basically, I mean, Heidi pretty much explained it, and it really is like, if you don't have a place where you can feel safe, and where you will be able to eat, and where you can feel hopefully loved, how are you going to care about going to the doctor, taking care of your body? I mean, you have to take care of your basic needs, like she said, you know, before you can care about the bigger picture. And it's really weird that you would think about your own personal health as the bigger picture, because that should be the first picture, you know what I mean? But, you know, people have a hard time, and it's good that, you know, that the Housing for Health came up with this. Like, I'm super proud to be a part of that organization, because I really think that's, I don't know, first time I ever heard that explained to me, I was just taken aback, because I was like, I've never heard of any group that does that or works for that, and I definitely want to be a part of that. So that's kind of what that means to me.
Awesome. Thank you so much. And Steve.
Hey everyone. For folks that don't know me, my name is Steve Diaz. I currently work for Housing for Health, but at the time of the pandemic, I was the deputy director of a community-based membership organization called the LA Community Action Network, one of the only organizations that does advocacy and direct community organizing in the neighborhood of Skid Row, and was also active in South Central Los Angeles. I think for me, when you think about housing and health, and you think about the pandemic, you're reminded of sort of how valuable and how crucial housing is, and how foundational it is, right? Because one of the first things that people were thinking about, it was, how am I gonna eat? How am I gonna pay my rent? Or how am I gonna get somewhere to be safe? And somewhere to sort of call a space that I can call my own. So those were sort of some of the key considerations, right? When you think about the amount of people that were facing eviction, when you think about the amount of people that were talking about, oh, it's an opportunity to take over spaces that weren't claimed. So really for me, housing and health is really around, similar to what Dr. Heidi said and Angel said, it's really about safe, it's a space, a personal space. It's really a supportive space. It's a space where you build community, and sort of it's a foundational space for sort of you to be able to become and evolve into whatever you need to evolve as a person.
Awesome. Well, welcome everyone. Beautiful. So before moving into kind of a deeper conversation around what each of these individuals were doing and kind of tasked with and in charge of and spearheading over the pandemic, and talking a bit about the quarantine site specifically, I think it might be important to define a couple of terms, just so that folks in the audience who may or may not be familiar with certain things we can just be talking about the same things. So a couple of things that come to mind that have been words that were kind of thrown around as we discussed this conversation: housing first as a model, as an idea. I guess we'll go one at a time. So I'll list a couple, and then you guys can pick who wants to speak to what. But housing first as a concept, we'll probably be talking about this idea of the housing continuum. So permanent supportive housing. You know, we can all speak about that, but what does that really mean? What does that look like? What does it look like in your experience, right? Interim housing, in your share just now, Angie, you mentioned interim housing and then permanent supportive housing, so I'd love some clarification on those for folks. And also, you know, the QI sites in general along that housing continuum. What role what did that mean, you know, for the longer process of getting folks housed? So maybe we could just start with housing first, if that's all right. I'm wondering, would you like to speak a bit to that, Heidi?
Yeah, and I think it's a really important thing for us to talk about because it's under threat now. Housing first is the philosophy that you don't predicate someone's ability to be housed for all the reasons that we talked about, based on there being a good duty. There used to be this notion that you would get housing if you stopped using, if your mental health was under control, if you did all the right things that was expected of you. And then it was sort of like an award or a prize. And the housing first model turns that on its head and says, no, again, housing is a fundamental right to which every human being should have access. You house them first, and then you walk with them while they work through their journey of achieving their best potential, which might include dealing with their traumas or dealing with their mental health or dealing with their substance use. And it's really important because before housing first, it was a way that we kept people out of housing. We said, they're not ready, they're not deserving, why would we waste our efforts and our hard-earned tax dollars on housing people who don't deserve it? The housing first model says it's not about bad or good. Everyone needs housing, and then we go from there. It's under threat now because we're hearing people say housing first doesn't work. Housing first does work, and even in our own county, we have supervisors who, because of political leanings and Republicanism and Trumpism, are talking about we don't like housing first. And I think it's really important for us collectively to fight against that because it's fundamental to our work. It's fundamental to establish that as a guiding principle, as a start.
And what does that look like now within the county kind of dialogue? You know, where is, you know, I understand that, you know, we're talking about it as a concept, but in implementation, where are we with that now? Given that it's under threat, what's more of the threat?
I think that the threat. Sorry, I just was taking a moment to recognize Dr. Burns in the room and Eric, who should really be at this panel with us, by the way, and Jen. Like, the more the merrier, because you guys are at the front lines. I think where the current discourse, and you guys can probably predict what way I lean, is moving away from this concept of inalienable human rights, among them housing, freedom from violence, access to health care, and that kind of thing. And I think this idea that, housing is a commodity that should be available only to people who prove themselves worthy fits in line with everything else we're hearing about, right, that's under threat today. And it really is, for me, a human rights crisis. We need to talk about it. It's our new pandemic that we need to fight. I think what we're doing, you know, at Housing for Health is we're not letting that deter us from saying we want to place the people who have the toughest issues in housing first, because that gives them a leg up, gives them the opportunity so that we can begin working with them in their journey to recovery and healing. And we hold to that. We definitively state we don't want to put people that we think are deserving into housing. That refutes everything that we stand for.
Thank you so much. Would you like to add a bit to that, Steve, about housing first from your perspective? Anything you want to add to what Heidi shared?
Not at the moment.
Okay. How about you, Angie? Because we could also transition to, as someone who works, you know, in the day-to-day of the permanent supportive in permanent supportive housing, can you define that for us? What is permanent supportive housing?
Well, I work in the clinical side of it, so it's a little bit different. I mean, it still really basically represents the same thing, which is trying to give people a place to stay and to have as their home, and not having to worry about where we're going to go next, or how long can I be here, or you know, all that kind of stuff. So, but the clinical team themselves, they support everybody by trying to go out there when people are having issues. Well, actually, it allows them to be able to try to work on their health care, because the idea, like you know, we just said they need housing first, and then when they're housed, then our nurses, if they have issues, like sometimes they have healthcare issues, they haven't been to a doctor forever, they're not connected to a PCP, or maybe they're not necessarily cooperating with their treatment at that moment because they don't want to for whatever reason. And so the nurses get to come in and they get to help them with all that. They can help them connect PCPs. They work with the ICMS, the case managers, and they help connect people. And sometimes it's not that easy, but I mean, my nurses, like, they have amazing hearts. So I think it's really great that you know, they get to be in that position. Like, and they all love it. They all do. And so that, I guess that's what that means for me. It gives the help that they're getting after the housing.
I can speak a little bit to permanent supportive housing because I think this is another thing under threat, and I'm like putting on my community organizer hat right now. So Steve, like, yeah. Okay. So there are two ways that like we house people, right? Again, we need to kind of push this dialogue that people aren't homeless because they're less than.
Right.
They're not homeless because they're mentally ill. They're not homeless because they're addicts. They're homeless because there's a mismatch between what they earn in income and the available low-income housing market. That is the primary reason why we have homelessness in LA and why it's growing, because that gap is growing. And so this idea of, okay, well, you know, whose responsibility is it to create more stock of affordable housing, right? Well, I ask you, whose responsibility is it to make sure that we have enough affordable housing?
Cities.
States.
Everyone.
Yeah, right? I mean, it's part of this as a civil society, right? And it was like pre-Reagan, there was this idea that, you know, as a civil society, we needed to invest a significant amount of dollars to make sure there was enough low-income housing stock to house everyone who needed to be housed, and that got gutted, right? And we haven't invested the dollar amounts. You know, I mean, in California, you know, the thought is we probably need to invest $8 billion to create enough housing, and we're like, if we can scrap together $1 billion, we're happy. We're not gonna solve this problem, right? And as more people become less able to afford, we're having more and more people fall into housing. So one issue is, how do we increase the availability of low-income housing stock? And we could just say, okay, here's a voucher, Angie. Here's an apartment. Steve is willing to let you rent this unit for, $500 a month. Wouldn't that be nice? Does anyone know what the average rent is in LA?
$1,100.
It's about $2,700.
For a
Most
studio,
people are on
1,100
general
for a studio.
relief and they
For a
only
month,
get $200
That's right.
a
It
month.
doesn't, the math doesn't add up.
70 hours a
right?
week at minimum wage.
You have to
For a
work like
studio.
2.5 minimum wage jobs to even afford rent. It's not humanly possible, right? So that's one option, but permanent supportive housing basically says, we're not just giving you a voucher or a subsidy, we're also providing you with support services. So you get a voucher or subsidy, plus you get a community-based support to help you before housing, get all your documentation ready, which makes you want to stab yourself with a fork, the amount of red tape you have to go through, find a unit, negotiate with a landlord who's willing to rent to someone who looks like you, right?
Yeah.
Get into that unit, and then it provides you with an intensive case management service provider who's a case manager who technically should have a caseload of 20 people to help you be. Right? Who can help you get your health insurance, help you get to your appointments, help you negotiate with the landlord who's not being very nice, or the, property manager, or whatever the issue is, but also make sure you have connections to the resources you need. And so at Housing for Health, what we say is, we do permanent supportive housing. You get your rent plus a case manager. That's what we mean by PSH.
Right.
Okay? And so for some of our people who are experiencing homelessness, they may not need the support services, right? They would do just fine with a rental subsidy and an affordable unit. But some of our clients need that extra support. Maybe they've had a lot of trauma. Maybe they've had a lot of brain injury.
Right.
Maybe they're having addiction. Maybe they're having mental health issues. Maybe it's just overwhelming to go from being in the street to being in an apartment all by yourself, right? They need that extra level of support so they can be successful in their housing. That's what PSH is. But PSH costs money, because it's not just the rent, it's paying for that extra case management services, right? And so we have to negotiate that with our money and say it's not just enough to build housing. God knows we need it. But we also need to provide that support, right? And that's what we mean by PSH. Okay?
Just a couple things I think are super important at the risk of sounding repetitive, right? If you look at the pandemic and sort of how the pandemic, who was most impacted in the pandemic, it was folks that don't have the means, right? We were the first ones to be out trying to find food. We were the first ones worrying. We were the first ones sort of helping to build our own community-based infrastructure because it didn't exist, or whatever existed was being taken away. And when you look at the ideas of what Dr. Heidi was talking about, housing first and permanent supportive housing, it's the exact same folks that are being supported and being taken into account, right? It's the folks that are the most neediest that oftentimes will not be taken in by the market, right? No one's trying to sort of create a luxury high-rise to house folks on $221 a month. They're trying to create a luxury high-rise that they can sell for $5.6 million a floor and make mass profit. So the sort of the linkages around sort of, as we're talking about these systems, that I feel super important is thinking about who's being impacted and sort of what it is that we're doing to change that around, right? One of the beautiful things that I love about Housing for Health individually is we support the most neediest folks. Like, that's our goal. Our goal is not to go find a middle class somewhere, someone in the west side. Our goal is not to find, our goal is to find someone that's in the river. Our goal is to find Steve on 6th and Crocker. That's our goal. And at the end of the day, like, we feel accomplished in meeting our mission if that's the person that moves on through sort of this continuum. Once again, not giving highlights to Housing for Health, as I'm not here representing Housing for Health, but as somebody who knows the model, right? And also just linking it back to the sort of COVID crisis, it was this idea of we need to do the extra step, we need to spend the extra time that sort of went a long distance, I believe, in sort of one of the key activities that I was involved in, which was sort of the vaccine clinics, right? Like, folks were nervous, folks were scared. Folks had no idea if they were gonna walk out with 4G, 3G, or even 2G, is what folks were saying. And I'm joking, but that's what folks were saying, right? And having folks be able to spend that extra time and sort of energy and learning what folks were worried about, having those discussions and sort of investing that extra time and building these sites that really took into account what folks are seeing here was crucial in sort of helping to create that infrastructure to save lives.
That's true.
Thank you.
Yeah, and Steve, would you mind exploring, like expanding a little more on where you were in the outset of the pandemic? You mentioned LA Can you talk a little bit about their efforts in the streets to support folks during that time and what you were most involved in?
Yeah, sure. So at that time, like many of us, many folks were wondering what exactly is going on and what is it that we do. We knew that there was a stay-at-home order at the state. We knew that there was the stay-at-home order at the city was coming, and none of us really knew what, when, how, what, why. But we also knew sort of because of our historic sort of connection in the community and identifying these issues that there was a key issue with public health, temporary public health infrastructure. So like for example, at that time there wasn't access to hand washing stations, there wasn't access to water stations, like there is now that it's growing, right? It's increasing. So one of the first things that LA Can did was we rolled out a sort of, in partnership with key sort of block leaders, was identifying these makeshift hand washing stations where folks can sort of access that itself. Because I don't know if folks know, it took about 2, maybe 3 months before the city was able to roll out some of the temporary sort of bathrooms and sanitation stations. So for us, that was key at the beginning. We also started rolling out basic survival programs, such as we were providing food to our members. So literally we were collecting food and we had a weekly drop off inside the residential hotels that existed in Skid Row, dropping food off because we felt that was important, that at the very least we couldn't offer 3 meals a day, but at the very least we could offer 1 meal or even sort of subsidize 1 meal for folks that was going on, right? It's always good to have that extra, you know, sometimes it's good to have an Oreo, it makes you feel good, right? And at that time we were all nervous, we wanted to do that. And then the third piece we were doing was really sort of trying to leverage what the environment was, what were folks doing, and sort of what were those partnerships that we needed to build. Because some of the partnerships that were being built, we had no idea about. Because when you're doing community organizing, oftentimes you're such in a bubble of confrontation, you oftentimes forget the other side of the picture, right? You forget what government is doing, you forget what other sort of philanthropy is doing at times. And sort of being able to understand that was super important. And that sort of led us to hearing the stories of how folks were going into some of the QI sites, also hearing the stories of sort of clinics that were happening that were very different compared to what we were seeing in Skid Row. I'll close out by saying one of the first interactions we saw when the vaccine rolled out, and I'm fast forwarding it, was the fire department came in some hazmat suits right at the corner of 6th and Gladys, between Gladys, Sirius, and 6. And literally, everybody was like, what are we here? Is it Armageddon? Is the zombie apocalypse? Right? Like that was not a space where folks would want to engage in dialogue. So that sort of led us to sort of, okay, understanding what other folks are doing, understanding how folks were trying to support the community, really lifting and using the key strategies of temporary structure, temporary infrastructure, sort of support food. So we were doing rental assistance. At the same time, we were also supporting at citywide level, trying to ensure that we had policies that kept people housed, because the number of projections were tremendously high around sort of number of people that were going to be out on the street that were end up going to be needing sort of some of this temporary and some of this interim housing that was being set up, that was here. And then the last piece was sort of the vaccine clinics. And that sort of was the evolution for us in terms of COVID.
Thank you, Steve. So moving over to Heidi, can you share from, as he's mentioning the QI sites, you know, as the individual who's very much the mastermind and spearheader behind this project, can you talk to us about, from your role in the county, what was it like? What did you have to do? And
I mean, the first thing I would say is there was no masterminding. It was sort of like trial by fire. we didn't know what COVID was. I mean, I remember, the first weeks coming back from Dockweiler Beach, which is where we set up our first isolation quarantine site, and I would come into the garage and I would literally like strip down and like douse myself with hand sanitizer, and I would stay in my car, for 10 minutes before leaving, because we just didn't know what we were dealing with, and it was incredibly scary. But then I think we had to realize if it was scary for us, what was it like for the people we were serving? Because I did have the ability to go home and take a shower and change my clothes, and could always have a mask and could have a hand washing opportunity, and a lot of the people that we were serving didn't even have an Oreo, right? Let alone a mask or the opportunity to protect themselves. And so I was constantly reminded of that. I think that our intent at the beginning was, we were given a directive, right? You at Housing for Health, DHS, are responsible for providing isolation and quarantine for people experiencing homelessness who are infected or affected by COVID. And so we were like, okay. And we landed at Dockweiler Beach with RVs, and yeah, it was something.
Yeah, it was something. It was beautiful though.
It was beautiful,
It was
yeah.
beautiful.
And I think what was also beautiful about it was like people who had before been doing like actuarial work behind computers all of a sudden were out there, bringing waters to RV campers, and just it was pretty incredible to see what people did, and Emily coming to spend the night with her dog, and whatever it took basically to take care of people. And we started to learn what we needed to do. It was really iterations, right? And I think that was what was so beautiful about it, is that collectively we had to keep talking. I remember how much we talked. Like we huddled in the morning, and we huddled in the mid-morning, and we huddled in the afternoon, and we huddled in the evening, constantly learning about how we could do things better. And we didn't always get it right. But I think we were able to put something together to try to bring, I think most importantly, some sense of comfort and peace to the people who we wanted to serve. And then from there, just as the pandemic raged on, and we recognized the number of people who needed support, we had to step in, and Eric helped operationalize, and Kevin and Jen were the medical brilliance, and Angie, was like a superstar nurse with Elna, and when you think about it, we had 700 staff that we were pulling from all over creation to basically take care of. I had to get the stats from Eric because he remembered, and I had trauma brain. But we served 12,200 people for 2 years. 12,200 people, and we stood up 13 different sites. And at our max, we were operating 8 sites at one time. And 65% of the people we served were people experiencing homelessness. And we have a point of pride for that, because they had some place to go. They had some place to go, for the first time, be in maybe a Motel 6 bed, have their own TV, shower, meals delivered to the door, EMTs come and knock in, how you doing? You saw our cabinet, we had whatever they needed, literally, whatever they needed to stay, whether that was bongs or beer, we had to do what we had to do. And it was truly miraculous. And I think that the other thing that I really take heart in was that we were for the first time able to break down silos, right, between Department of Mental Health. We're like, whoa, blah, 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 and then all of a sudden we could have a, fast line to the emergency response team, or they were doing holds in our motel so people didn't have to go to the hospital. And The public health people, you know, were like, la la la, around her giving pot, but didn't get in the way, right? Like, you know, we could start thinking about giving methadone and starting people on methadone and all the things that, you know, even today might not be possible, but we were able to make possible at that time, which was really, really important. And Eric reminded me, like, 90% of the people that left isolation and quarantine, which was usually after about, I would say on average 10 days that they were with us, went to a destination. They didn't return to the street. I wish more of them had gotten to PSH, but that's a whole other story. We don't have enough PSH. But we were able to get them somewhere where they could continue to recover and sort of like continue to, on their journey of improvement, which I think was a real testament to the work of not only the health partners, but we also had other agencies, right? Like so many other agencies who had experience working with this community, who were doing case management, who were making runs to McDonald's. If someone needed a Big Mac to stay in the hotel, we would go get them a Big Mac, right? Or if someone needed their paperwork filled out, or someone needed to reach their family in Arkansas or whatever, we made it happen. And it was really quite something.
They were super impressive. Like, I remember watching how much work they do to try to find somebody a placement. They worked really hard. I was like, wow, I'm like, why can't we do this all the time?
Yeah.
But I recognize that, you know, we just don't have enough, and I know that's what we want to do, but that's the one thing I will say that was kind of cool about COVID, which is kind of a stretch, but it was really kind of cool to see, like, that it can be done.
Yep.
And that people actually got a place to go, and it wasn't just like, oh, well, see, you know, good luck. And that was really, really awesome. I really admire them. I would just, I was really, really happy that, because initially, like, when it first started, I didn't even know that. And when I started to see it, I was like, oh my God, this is amazing. So that was really cool. And I'm glad people got a place to go. I mean, I know a lot of people actually and didn't want to leave us for a while, but they had a place to go. I think it made a lot of people happy, and I think a lot of people that had been like really on the street for a very long time, it was a real change. Like she said, they had a shower, they had a bed, and I think that's wonderful. I mean, it's sad that it took a freaking pandemic, but you know, that's really cool.
Well,
Can I
that's
just-
what, yeah.
Yeah, I felt that it's one quick important thing, right? If there's one thing you leave from this conversation, you should definitely leave with, is COVID showed us that it was possible.
Yeah.
Yes.
Right? Money was being printed, locations were being created, services were being done. So like, oftentimes we doubt the ability of stuff to happen. Like, after COVID, we should not be doubting anything except that it can be done.
Yes.
Yeah, no, absolutely. So what I want to deepen into a bit is how it was done, like more specifically, you know, because so maybe Angie, if you want to share a little bit about your day-to-day experience at some of the sites, and just what was it about those 14 days, maybe more or less, depending on the case, that made it possible for that person to be at place somewhere, based on either your experiences caring for them or conversations with the case managers and social workers that helped place folks.
Well, I mean, the community partners, like, I think we had, was a PATH, and we had
Lots of different.
we had People's Concern, and we had several different community partners that were pretty much doing all the placement stuff. The things that we did kind of in the nursing is, a lot of it had to do with intakes. Like, we had to get the information first and find out where they would be willing to go. And sometimes it took a lot of talking to try to make people feel safe about where they're going to be going, or to make them believe sometimes that we weren't just going to cut them off and be like, see ya. Because some people didn't really believe that. It's, which makes sense, I guess. But yeah, sometimes it took a lot of talking, and it took a lot of compassion, and it took a lot of empathy, and it took a lot of trust from the people we were trying to help. And faith, because I'm sure that wasn't easy for them either. Yeah. But day to day, what did I do? Day to day was It's just, I don't know. It's kind of hard. It's like a little bit of a blur. It's actually a lot of a blur. But I mean, I keep seeing these pictures back here, and it's like, wow. I mean, I keep getting distracted. I'm like, oh my God. I'm like, oh my God. But yeah, I mean, it was. I think I saw something day to day. It was just really busy.
Yeah.
And well, for me it was anyways. And it took a lot of inventive thinking, like stuff like how to get up an elevator and not have PPE in, and do have PPE on, and how do you get in a hallway, and just like there was a lot of things that we had, like you said, that was changing all the time. And I don't know if that's really necessarily what you're asking,
That's
but
great, yeah.
I mean, I think what I would say is that one of the things that we didn't do, which I think is really important to Steve's point, is we didn't just deal with them as like being COVID positive or COVID exposed, right? We took the whole person.
Yeah.
So when we brought them in, we got to know their whole person, right? Which meant we had to deal with the fact that, they needed to get the opiate or they would leave. We needed to deal with their trauma. We needed to deal with their domestic violence and the fact that their boyfriend was going to show up and cause issues outside our gate. We needed to deal with the fact that, they had been so traumatized by other providers who had promised them things, and here we were promising them things and was it going to happen, and we had to deal with the fact that they came with 6 bags of Chihuahua and a parakeet, right? We had to deal with
Sometimes 2 parakeets.
Sometimes 2 parakeets, and we had to be able to manage it all because we had to manage the whole person, and we did so gladly because that was important to, in that moment, to treat people well, right? Because we could have been very sterile and just dealt with, okay, you're going in a room, you can't leave, we're going to drop off your meals. But we didn't. We took the time to get to know them and understand them and manage their issues. And I think what was painful for me, and I don't know about you, Angie, and Kevin and Jen and whoever else was there, was like knowing that in this moment, like we had this beautiful like holding, and like knowing that when they left, where were they gonna go?
Yeah.
Right? That was what was so hard. But at least like we took comfort in the fact that for those 10 days, we did the best to make them feel as comfortable and whole and respected as possible, and that in and of itself was a mitzvah, right? But I think one of the things that you probably heard about a lot that we didn't administer was the PHK programs and the PRK programs, which was this idea of like bringing in all these dollars to create interim housing that would stick, and then this promise that anyone who was placed in those sites would get an apartment. Did any of you go through that, where you were placed in a PHK or a PRK? And like, what was hard was, it was great. There was a lot of funding put in. There were a lot of people put into housing. Like, we could discharge people from our IQ sites to a Project Home Key site or a Project Room Key site. But then what we started to notice is the funding would run out and they didn't get their permanent supportive housing, and they ended back out on the street, which did feel disappointing, right?
Yes.
Because it was like, if you think about it, like we started them on a path, we showed them building trust, helping them feel like, hey, I can have a better existence, and then to have it sort of like was, I'm sure, but I actually have to say that I haven't really ever gone back and found someone who experienced that to say like, what was that like, right? Like, I wish we could.
Yeah, that's what I'm curious about, is given that so many folks were placed and discharged from your sites into some kind of shelter, what, it sounds like follow-up wasn't necessarily possible, or if it was, what did that look like? And if it didn't, what could it look like in a way that would be sustainable? Who would be those people? How could we?
Well, we don't have the people, Steve. Maybe the people who were running those sites, right? I think it's a really good question. I don't know if anyone experienced it in this room, but like theoretically, they should all be in the HMIS system. I mean, the last I heard, it was only like 10% of people who were placed in those sites got permanent housing. But I don't know, like the other 90%, like if you went back and you talked to them like in 2023, would they say they were better off than they were in 2019 because of that experience? Maybe. I don't know. I'm assuming someone looked at that, but I actually don't know.
Did you want to speak to that?
I'm trying to frame my thought.
Yeah. Take your time. Yeah. Well, so one of the, just to follow up around the, the things that you all had access to during that time that normally it sounds like you don't have access to. One thing that was brought up last panel was like access to records between, the previously siloed counties. So I'm curious, why, can you speak a little bit to why that isn't the case all the time, and just for those of us who don't know about that, why was it that during COVID that was all of a sudden that was accessible, and why is it that didn't necessarily continue? Or did it? And if it did, how is that sustaining now? How are some of the innovations and novelties of the time being sustained, if at all?
Well, I don't know. I mean, I think the records piece was mainly because we were a medical unit, right? Even though I'm talking about the fact that we were dealing holistically, because we were a medical unit, and Angie, as a nurse, was sending the, release of information form to a hospital to get records. Whereas, like, if a community health worker is doing that, they'll be like, well, blah, 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 and they don't get the records. There was something different about being in a medical unit, which made it a little bit easier. And what I would say is, like, Sheila, who's like our, Shivul Bataille, getting records now, because she's a medical person, can get that, whereas like other people who are doing case management probably still struggle. I don't think that has changed because of COVID. But I do think that there were, I think to Steve's point, knowing that it's possible has given me hope. Because sometimes it can feel overwhelming and like there is no hope, but I know that given the right amount of money and the political will, we can do better. And having had that as an example is very motivating. I think what's hard for me when I put my pessimistic hat on is like the money and the political will and the like cutting down of red tape was probably because people in power were afraid they were going to get COVID. And because like fentanyl overdoses and like poverty isn't contagious, like will it get the same level of attention? I don't know, that's my pessimistic me.
Yeah, I mean, I hate to be kind of pessimistic, but I kind of feel like those gaps got bridged, and we got to connect with DMH and DPH and DHS, and we all got together because everybody got real scared. And rightfully so. I mean, look at a lot of people died. It's not great. And so, once again, it sucks that it had to be a pandemic, but like she said, it can be done. And I mean, I can say this. I've worked in hospitals. I've worked in psych facilities. I've worked in a lot of different places, and it's always been, where I've worked, it's always been their silo. DPH is DPH, DHS, DMH. And I worked for the state as well. It's the same way. But when that was happening, it wasn't really like that. And now I talk to more DMH people and have more interaction with DMH people than I've ever had, that I've ever seen, and that I didn't think was really
That
possible.
has persisted, right?
Yeah.
Like in our
great.
PSH program and in our new inner housing program, because of the relationships we forged, like I have Latina Jackson on DMH on speed dial, like because of that COVID experience, and we built that relationship of trust. It was like forged in that fire. So now you can be like, hey, Latina, want to do this? Be like, sure. So it did enable that in like that spirit. Now, whether or not we have necessarily, again, the funding and like the political will to do everything that we want to do at the scale, no, it's going to be more incremental, but I still feel positive about the direction we're moving in terms of integrated care delivery.
Yeah, just a couple of thoughts. So usually I'm always the one that feels like, oh, this stuff's never gonna happen again, and it's all bad moving forward. But I feel torn when it comes to the innovation that happened during COVID and how it's being implemented moving forward. Let me give my man a second so you can sit down.
Go sit down.
Thank you, buddy.
Thank you, sir.
Thank you, sir.
Because when you look at the relationship piece, right, and how institutions might not have institutionalized or been able to institutionalize a lot of the sort of removal of red tape, there are relationships, right? At the institutional level, at the community level, there's better relationships with sort of providers and sort of folks that we're able to link through the community health worker model. That sort of opens up more people to be willing to sort of access housing. I'm thinking about the example of like Pepper, which I'm sure a lot of people in this room know, right? That's a beautiful case of something that went from point A all the way to point Z, and probably would have never had happened because of the pandemic, right? I think about sort of how programs are now evolving, right? And I think about the campus that the Department of Health Services is planning for Skid Row. And I think about how a lot of that community inclusivity is sort of being at the forefront, right? And it's really being purposefully being put at the forefront to ensure that folks are able to sort of not just see it as another location, but see it as a location that sort of is here for the community, that was created by a community vision, and is supported for the community, right? By the community, for the community, with some parts of other parts to it. So I say that to say that I wish there was the energy to sort of print money again and sort of house everyone, because you need to talk later, right, bro? I'm joking, everyone, I'm joking. I say that to say, right, like I wish there was that energy, but I know that the political wills sort of shifted. But I also just think that at the same time that folks were scared, right? We know what moved people, and now from like a people-driven lens, now it's on us to sort of also take the overdose crisis, take the crisis of poverty to the next level, and really articulate that and sort of scare people into taking action. And not necessarily scare people in the sense of, oh, you're gonna die. Scare people in telling the story, scare people in bringing people together, scare people in sense of sort of taking those spaces that are sort of should be community driven and have community voices at the forefront to move forward.
I love that.
Yeah, and I wanted to sort of speak to that a little bit because I think this is sort of like a dive deep example of that, Steve, but like in addition to running the isolation quarantine units, one of the other things that we needed to do as DHS was do testing and vaccines. And Steve mentioned, his part in COVID vaccine in Skid Row. And our DHS team, I think, vaccinated about 45,000 people when the vaccines came out, which is like huge. Like a quarter of all people experiencing homelessness in LA County got vaccinated by a DHS staff person, which is really amazing. But I remember, because we had money, we hired data people. And one of the things that we started to do was we looked into different service planning areas and we said, okay, in SPA 6, I'm gonna misquote numbers, but I'm just making this up. 35% of people experiencing homelessness in SPA 6 are Black. And we looked at the number of people who'd gotten vaccines who were homeless, who were Black, and saw it was only 16%. And we were like, wait a minute, that doesn't add up. And what we realized was that our initial approach wasn't reaching a population that really needed it. And what we did was we turned to community members. And we organized with community and we said, hey, setting up pop-up tents with people looking like Angie and me isn't working. So what do we need to do to vaccinate, people in the community? And they were like, well, we need to have people who look like me and who can walk around and who can sort of like deal with some of those questions and that fear and that suspicion. And, you know, if you did it this way and if you did incentives and if you went into the barber shops and you did all of that kind of stuff, I think you'll see those numbers go up. And we did, and we started stipending community members and we started doing that like block level work. And like we were able to close that gap within like 2 months.
Oh, wow.
And I think like it was an important lesson, which I hope we don't lose, which is the power of community engagement in reaching populations that even those of us who are trying to do work in the vulnerable, even among the vulnerable, there are those subsets that are even more vulnerable and require a different type of approach and being willing to be creative and get the community involved to reach everyone. And it's something that I worry we lose now, because I think we've all kind of gotten back to being very professional and it's very sort of like hierarchy driven, is not losing that reach into the community, which was so critical to us closing some of those gaps that we were forced to study during the pandemic, because the federal funds were like, you have to show us, you know, what is the race, ethnicity of the people you're vaccinating? What is the gender of the people you're vaccinating? What is the age of the people you're vaccinating? And like now I think about, are we doing that with same things we're trying to do now in terms of percentage of people in permanent supportive housing, percentage of people who lose their housing? Are we looking at the populations that we're failing and thinking about how to engage the community in reaching that population?
Thank you guys so much. Yeah, well, there's much more to add, but yeah, one thing I wanted to, so yeah, some of the key pieces, there's like that, you know, breaking down the silos, integrating the care, having this kind of like radical approach of being, I mean, it shouldn't be radical, but being able to see the whole person and treat the whole person. Can you speak also to and maybe starting with Angie, like the quality of just like the care and the love and the acceptance that kind of permeated the sites that you worked on, not only between like patients and staff, but also like the camaraderie that was shared between like staff members, and how that contributed to the success of keeping folks here, keeping people sheltered.
That's really broad. There's a lot. I mean, because there's the compassion and love and kindness that we felt for the people that were taken care of, for sure. I mean, because it was very different. It was very different. It's not, I mean, you know, you take care of somebody in a hospital or a SNF or even a board of care, it's nothing like that. So you have to make a lot of different kind of allowances and a lot of different, you have to, I don't want to say it like that because it's not really, but you kind of have to look the other way about a lot of stuff. Not in like an unethical way or anything like that, but you just kind of have to learn to just, like she was saying, you know, the lines and the professionalism, like sometimes you just can't do that and be in that scenario because they need more than that. Everybody needs more than that. There was like, I mean, the staff was really burnt out. We had people that were working 12 hours a day, 7 days a week. You know, people get tired. People get moody. It happens. But then at the same time, the same people are the people that are going to be there for you when you need them. And there was a lot of people, a lot of things we laughed about. You know, it was just, you know, I mean, I know that's a very shortened version of a lot of stuff, but I can just say that, you know, the camaraderie between the nurses and even not just the nurses, but the project managers and DMH and everybody else like that, it was really pretty inspiring, actually. I know I said that a lot, but it really kind of was. That whole situation really kind of was when you look at it. It's like, I mean, I don't know, to me it really was. And people that you thought would just normally just be mean and stay mad, they got over it. We moved past it. People got fights, not fun. They moved on.
The people who were mean, interestingly, tended to be people who had homes to go back to.
Right? That's what I meant. Actually, that's what I meant. I'm talking about the staff. Not the people. I didn't say that. I meant the staff. Okay, so this was a staff interaction camaraderie I was talking about. No, the people that we helped were actually pretty thankful. They were pretty nice, and it was good, but I was talking about the staff, yeah. So, you know, but everybody came together when they had to. And, you know, if we fell a little short, somebody else picked it up. So there was a lot of that. And thank God the people that we tried to help were very understanding, and they had to be very patient with us because that was not an easy situation. Like, you really look at it and you kind of go, well, you know, yeah, really nice place. It's better than where you've been staying. But who wants to be locked in a room for 14 days by themselves, right? And the TV's great now, but even I get tired of that after a minute, and I'm a fiend for television. So, you know, they had to have a lot of patience. And plus, people that smoked, they had to wait to go out when we moved to a different place. We had a couple places that had balconies and they were separated enough to where they could smoke and it wasn't as, you know, as bad. But holy crap, when we moved into the Sheraton, while it was beautiful and it seemed like a really great idea because it had so many rooms, it was not great for people. They got really isolated, and you know, they had to wait to go smoke in different breaks. And most people, or not most people, but a lot of people that smoke a lot, and they smoke constantly. They don't want to wait so they can go out for 15 minutes. And then if you had a dog and you came with a dog, you can only, or a pet, you can only go down for. So it took a lot of patience on behalf of the folks that stayed there. And so thankfully they were patient.
Go up a lot.
Actually, surprisingly, no. I think actually actually it didn't go off a lot. I think the roof alarm went off a couple times, but
Yeah, I mean, I think people were really generous that way in the sense of like everybody knew we were all in it together and it was uncomfortable, but I think the staff really tried to make it low barrier enough that people respected that and they respected what we were trying to do. So that wasn't really an issue, and I think the leaders like Angie and Kevin and Jen and Eric really made a point of taking care of each other just as well as taking care of the clients, because it was really hard work, very traumatizing, stressful. We were tired, we were scared, we weren't seeing our families, all of those kinds of things, and I think there was this spirit of like, we can do this together, that was, you know, really incredible. And I think like, in some ways, we often talked about like, was it harder or easier than being in like the intensive care unit in the hospital, right? Where that was like, you were wearing hazmat suits and you're doing 12-hour shifts and it was really, really hard work, right? I mean, Sheila's saying yes because she lived it. But it was different, right? I mean, it was just as hard. I mean, you can't do comparative.
yeah.
It was different, but it was still really intense work. And I think the intensity was because we did want to address as many issues as we could in that period of time we had them. Yeah.
And it was because in the beginning, well, not, and actually pretty far in, I was still working in the ICU as well because I had a second job working in the ICU, and so I was still doing that. The reason I stopped working in the ICU is because I was getting so many calls from the COVID side. I was like, I have to take care of my patients. You guys need to stop calling me.
Yeah.
So, it just became like, okay, you know, they had a lot of people, and it was very different, but they were both equally difficult. They really were. But thankfully, we had a lot of people that were willing to do it, and a lot of people that were very patient. I just keep saying that they were very patient.
Steve, I noticed you've been making some notes over here. Do you want to add something?
No, I was just thinking about like, I keep going back to the relationships, right? And as Dr. Heidi was talking about the community outreach workers, a good friend of mine was a community outreach worker, and I just went to go visit him, and I just wanted to highlight what he was doing. He still sort of keeps track of all his team, so they all talk, right? Going back to this whole idea of like teamwork and camaraderie, like they've been done for about a year now, maybe 2 years now. It all seems like a blur, but they still talk to each other, right? The Skid Row Action Support and Technical Assistance Team, a lot of those folks came from the community health worker model and were engaged in the community health worker sort of work. And we're all together, and the camaraderie was a little bit easier just based on those relationships. So I was just sort of reflecting on the power of relationships and how it has really lasted for a long time. with the folks that I know I engaged with.
Yeah, it's interesting. There's a foundation called the RX Foundation that was giving little micro grants to these community-based COVID vaccine efforts across the country, particularly in areas where there wasn't a big county agency presence. And a lot of those relationships and little bands that were formed are still existing, but they're looking for a new home, right? Because there's so many issues that still need to be addressed that they're anxious to get their teeth in, but they need that money and they need that validation. They need that platform. And one of the things we were talking about in a forum was what is the responsibility of Department of Public Health or Department of Health Services to keep funding those community health tribes, but maybe have them pay attention to something else now, right? But not lose what was built. But I think we're struggling with that.
Yeah, I want to explore I want to leave a lot of time for questions for sure from the audience, but also, kind of, summarizing some of the things that you guys have shared, but then looking forward, it sounds like there was, the fear of the collective was a huge factor in making this happen and possible, and which may account for, besides funding and other things like that, and political will, as you mentioned, why it's not sustaining and continuing. But if we could, because I'm anticipating, a lot of folks when they hear from people talking up here, they want to say okay, well, what can we do? What's going to happen? What's the goal? What's the solution? So given that we might not know the answers to all of that yet, but I'm curious from your experience, each of you, if you could talk about given your role, what is it that you would need to be successful in contributing to progress in terms of housing individuals? What is it that the county needs? What partnerships do you need? What resources do you need? What kind of, I know that's a huge question, but just to kind of position, to look forward a little bit for what, given that there's hope, but there's also some pessimism, where can we point our arrow, just even if it's just 1% or 5%, 10% ideally, more towards progress here. And whoever wants to start.
I'm looking at Steve.
Steve, why don't you start? What do we need, Steve? What do you need?
First off, I just gotta say I'm blushing because Dr. Heidi was I'm looking at Steve. I think there's a couple points or a couple perspectives where I would start off with. First of all, I feel like the political will needs to be created. So that starts with people like us in this room, sort of identifying solutions and sort of means to sort of implement those solutions. So it definitely starts with people. I think secondarily, there's going to be the renewal of Measure H coming up. Yeah. That's going to be a great opportunity for folks to sort of talk to your neighbors, talk to your friends, talk to your churches, talk to your block clubs, whatever, because we need resources and resources need to come. And creating dedicated funding sources are very important in order to ensure that happens. I would say from the Skid Row lens, there's something called the Skid Row Action Plan that's really looking at transforming sort of health and sort of communities concepts and sort of bringing together for more permanent housing, the Cracker campus that I was talking about, and sort of enhancing health services as well. So really thinking about how to get involved with that and sort of supporting that. And yes, I just built a campaign I'm working on. But I think the other piece is call the question, right? Be ready to call the question and the tough questions, and don't just walk by so-and-so. Wonder why is it that X person's on that street? Wonder what are the institutional barriers that exist, and take an action against that. Take an action to address that institutional barrier. Because at the end of the day, if we don't take action ourselves to support one another, who's going to? And that was a key lesson I personally learned from COVID.
I'm looking at
Yeah, I mean, kind of just looking ahead, given bringing it back to the idea of being successful, transitioning folks into housing, you can kind of, if there's something you would want people here to take away with what can be done, or what you would need as someone, as a nurse, for example, as your role as a nurse, what would you need in that
piece of the puzzle to be more successful in making sure folks are sustained in housing.
Yeah, I really, I hate to say it, but I really need money.
Yeah, yeah,
And we need,
yeah.
you know what would be amazing? If we had a bunch of like people that were like, you know, the developers that are going around doing all the developing.
Yeah.
If we can get some of those guys, 'cause there's like a building right by the Staples Center. It's huge. They ran out of money. And it's just, yeah, there's 2 of them. They're getting graffitied now. They're just like half done. Like if we could get some developers to feel generous, that'd be amazing. And that's really not me as a medical person, that's just me as a person.
Yeah.
And then of course, you know, it's always nice to have more clinical help, like more nurses, more MAs, more LVNs, more community health workers. We could definitely use more ICMS because their job is so hard. Because they're supposed to have like 30 people, some of them have 50.
This is a housing case manager.
Yeah, oh yeah, sorry.
What do you call it?
ICMS.
Intensive
case management services.
Okay.
Definitely need those.
Yeah.
Oh, yeah.
They were
They're
hard.
rare.
And
I knew that.
they're kind of, sometimes they're our main connection to helping people. But sometimes they're so overwhelmed that they can't really help other people, and so it makes it a little harder. So we could definitely use a lot more of those folks. And, yeah.
Cool. Yeah, thank you.
Yeah, I mean, I think going back to the beginning, we need more low-income housing.
Yeah.
There's a lot that has to go into that, right? It's not just about money, it's also like NIMBYism and making sure that people don't get in the way. There are lots of excuses that are thrown up about why housing isn't being built fast enough. And we do have some power as voters to change that, but also like show up at those NIMBY town halls and present the opposite narrative to why it should be built in Venice or why it should be built in Santa Monica, et cetera. Like, there's a lot that we have power to do as people. We need to change the narrative and make sure we're normalizing the face of homelessness as being a product of growing poverty, not of depravity.
It's not our fault that the services don't exist there, right?
Yeah.
It's the system's fault for not having those services.
And I think also, like we were talking about with permanent supportive housing, realizing that housing in and of itself isn't enough. We need those intensive case managers, we need the mental health services, we need the better access to substance use treatment if people are interested in treatment. If they're not interested in treatment, how do we help them keep safe and not die while they're using?
That's right.
What are the things that we need to do to make sure that happens until they're ready for that next step in their journey? I think that that does mean that we have to invest more, and when you think about the fact that many of the people who work with people experiencing homelessness themselves don't get a living wage, that's a travesty, right? We have to figure out, like, how do we make sure that they're getting paid, that they have opportunities to excel, and I think to Steve's point, like, how do we make sure that we create opportunities for people who have been homeless to promote into that work, right? It's like poverty remediation comes with giving people opportunities. And I think that's really critical, and also for me, it's not just sticking to peers, like we have peers, but then like making sure that they have the opportunity to grow and promote, get educated, make a higher wage, bring it back to their family, all of that's really, critical. I think, I wanted to shout out to Kevin, not to embarrass him, but he's wearing 2 hats today. One is he was, really instrumental in terms of being the medical director for IQ, but he now is sitting at LA Care, which is like the biggest managed Medicaid, entity that serves our people. And the health insurance plans have always sort of been the bad guys, but I think they're starting to see like they're not the bad guys. And when you think about like money, a lot of the money is flowing from the state through health insurance to pay like through Medicaid for housing subsidy. Did you know that you can get your housing deposit paid through Medicaid, right? That Medicaid will pay for a caregiver to come in your home if you need help with bathing or dressing. That Medicaid could pay for your housing navigator to help you find an apartment. Medicaid is paying for your intensive care manager. you know, one could argue, like, should that be on the shoulders of the health insurance system to pay for things that, again, remember when I asked, like, whose responsibility is it to make sure that we live in a civil society and we have access to basic human rights?
So you mean them ladies that I cuss out every morning that be calling me to help me?
That's right.
Wow, I'm gonna be much nicer to them.
Good. No, but I think it's true, and I think like part of partnering, and you know, I think Kevin is a testament to this, is like, we can also turn them into good guys to partner with us, and I think more of this sort of public-private, you know, partnership is really important because not one of us is going to solve the problem, right? We need a whole table of people who are coming together and pooling resources, right? This is a global problem that needs a global fix, and I think that that's, you know, really, really critical. I think that one of, I think the biggest things for me, and again, you're not surprised by my political leanings, is the threat that we face as a country, right? We're moving away from this idea of what it means to be a civil society and those basic human rights that we're going to see more and more violated. And what is our responsibility as a democratic people to make sure that we are presenting opposition, right? We're fortunate enough to live in California. As hard as it seems, like think about our brothers and sisters in Arkansas or Arizona. Like, what can we do also to support them? Because we are a part of a bigger global community, right? And there are people who, believe it or not, are even more oppressed because they don't have us. They don't have this opportunity. And like, I think we also have to think about how we advocate for beyond just ourselves, which feels overwhelming. But I think it goes back to that idea of like, we can't continue to see this as like a narrow sliver that needs to be like shoved under the carpet. Like, we're here and we're important. We belong and we matter.
That's awesome.
And that we really do want to create like opportunities for growth for everyone. But it means we have to give preference to people who struggle. And that's hard for us to do as a capitalistic society.
Yeah, right.
And that's probably a larger discussion, but I think like what I'm feeling in this room is like we have it in us, it's just figuring out what are those levers we need to pull.
Yeah. Just one thing to add to that, just like also like looking at folks in this room who are very artistic, right? Artistic is a way of highlighting struggle and is a way of highlighting sort of messaging, right? So it's telling a story, telling a narrative. So using those skills around research, using those skills around connection, using those skills around storytelling is a key sort of tactic that can be used to uplift sort of the future and sort of begin to have another narratives told and have folks understand and see that, right? Because we can talk, we can preach it all the time, but if folks aren't able to see it or feel it, it's a different story.
Okay, well said.
Thank you. Yeah, just one moment.
I don't hustle out for real. I really don't hustle out.
No, I just want to, I want to thank you all so much. And I think that sometimes like the best parts of the panel is really coming from the questions from folks around. So I'm going to, not ask any more myself and invite another question here, Lorraine.
Hi. Thank you so much for sharing. Thank you so much for what you did. And you know what? I just thank God that you guys made it through it. I really know it must have been overwhelming, and you had to go home to your own family with all the things that you had to deal with. And I just want to say thank you. I didn't get a chance, and here I am thanking you for working behind the scenes and doing what you do to help people in need. I know it was devastating. My question to you is, how have you changed the system from going through that terrific, devastating new planet that you guys went through? Did you learn to change things, to deal with things better today, or did it just stay the same?
Well, I think for myself specifically, it changed the way I looked at things a lot. I don't know that it's not like a real global change in it, but I think it changed a lot about how I view things and how I view people and what I can and cannot do. And in that, I have been able to teach other people that. And I have been able to give people a hope when they don't want to, they're frustrated or they are upset with their work or whatever. I've been able to sometimes inspire them. And, you know, I learned a lot about building teams, which is, I learned a lot about that. I learned a lot about building teams. And so I have built some teams.
Well, I want to like push Angie a little bit because when she started working at IQ, she was just like, "Oh, I'm a line nurse. It's okay. It's all good." And like we forced promoter to be like charge nurse, and then we forced promoter to be IQ, and then we forced promoter to be a nurse supervisor. So like what I would say is like we knew she had it in her, but it like pulled it out. And I think not only did you learn how to build a team, you excelled at it. And I think like what Angie brings to her work today and leading, you know, the teams in the PSH space and IH space and ERC space is that sense of like, we can do this. Like, yeah, you have all these problems, we can do it. Like it's surmountable. And I think that spirit is so critical because it's so easy to be like, oh, woe is me, I can't like do this. And I think Angie is one that she's just that kind of personality, but I think like she learned you can do it because if you could do it during COVID, you could do it now, right? And I think like, so she always sells herself short, but she really, I have seen her blossom from a seedling to like just a big old flower, big old sunflower.
Thank you.
You just started out with the things I wanted to hear you say. It was about me learning how to apply. And thank you very much. It was really, and then she hit it on the nose. All right now, thank you.
All y'all did so well. All y'all
Yeah.
I'm finna light this place up like I did the last time y'all was here.
Oh, not yet.
I ain't gonna do
You had a question?
Got a question.
You got a question? Okay, cool.
How many of y'all know that it's about 20, 30,000 people live down here on Skid Row that mess their own self up? Because I've been down there for now 29 years. And I have seen things like this. People, you know, like you be in the GR and they put you in, help you get into a housing. That's how I did too. But I like what they do is they got a thing about eventually they get on SSI, right? Then they decide that I ain't gonna pay no more rent no more. I'm just gonna let y'all throw me out. Now what Section 8 or anybody else gonna give them a house? People, because I talked about people. Well, that man right there helped me to become what's called an activist. I took a year activism with LA Can. God bless you, LA Can. And they taught me how to a lot of shit I didn't learn though, right? But then I talked to people about the housing. You dig where I'm coming from? You know? And do you know that a whole lot of people get out of jail, get out of their home because they laying up in there selling dope in the damn house? They ain't gonna tell nobody that. You dig where I'm coming from? You know, whole lot of them. You don't get put out of your house if you ain't doing nothing. That's against the law. You know what I'm saying? You know, and
They still deserve help though, right?
yeah, they do. I'm talking about. I just said I talk.
Oh, you're getting
I hit
there.
you with the
All right,
housing.
I'll hold on.
I don't know nothing about the house. Well, I'm gonna come into y'all too. I ain't gonna do nothing. I'm gonna tell you how I appreciate you and everybody I see on that thing over there. You know, I appreciate you. I have my place. I wasn't dumb when I got my SSI. I kept on paying. I still got it right now. You know? I think that people should monitor those houses they build. Because a whole lot of those doggone places, the managers only put a certain race in there. It's 50, 60 people is SA and white and all that and stuff. But people are covered, like the black people and stuff like that. Because this happened to my girlfriend. She called somebody and they talked to her so doggone good about how, come on down here, you got a voucher. She had a voucher. Yeah, come on down, we'll put you in here. You know what I'm saying? And then they didn't know what but they act like I ain't talked to you on the telephone, I don't know who you is, all that old kind of stuff. See, that's prejudice. That's why some of them need to be monitored. Have a limited, you got to, for the people of color, have some housing in there, white people, Mexican, Chinese, whatever. You don't take no housing and don't do that kind of stuff with it. And that is what is happening with it too.
So I'm gonna jump in real quick just because I know and flip a little bit what he's saying, just so folks know. There was a study done by the Los Angeles Homeless Service Authority on Black people experiencing homelessness, right? And one of the factors that was highlighted was institutionalized racism that existed, right? So, and how that impacts African American folks and sort of how that has an impact on who's homeless and sort of services that folks are receiving. It's important to sort of recognize barriers that exist, and it's also super important to sort of create spaces for folks to acknowledge those barriers. I jumped in and sort of got in the conversation real quick just because it's almost late and I really need to go to the bathroom. But I do want to acknowledge like the sort of the other side of what he's saying in terms of that, and sort of put that out there as we're talking about sort of the impacts and sort of recognizing sort of some of those institutional sort of issues. Tom?
Yeah, in terms, you were talking earlier about moving forward.
In terms of, there's the group of supervisors, board of supervisors who are all elected officials, and then they have key people in their offices, and you have the mayor, you have the city council, other elected officials, they have key people in their offices. In terms of like what you experienced with this during COVID and even coming here tonight to do this, are there certain offices or elected officials or even like the chief of staff in an office that you feel you've gotten connected to over the past couple of years who you would literally even encourage us to, like, in terms of voting in the future, in terms of policy, in terms of just, you know, advocacy of taking these lessons and making them systemic in nature, are there key people that you feel you've gotten connected to over the past couple of years?
But the people
I will have
that
to
do
get
that
to
stuff.
Lee, we're gonna hear the answers and then.
Yeah, I think I have to talk to you as a private citizen about that. Yeah, and I'm happy to. Yeah.
So there's a question over here, Eric.
Hi, I'm Eric Dean, community health worker. I'm a Skid Row resident, Skid Row activist. I was trained by Los Angeles County's whole person care program, Dr. Behforouz.
Great.
Good to see you again, Heidi. It's been quite a few years. You know,
I wish that program was still around.
yeah, you know, it is. I mean, you know, other itinerations of it. Okay, so you know, and in fact, what you guys have been talking about is the whole idea that you know that there's more of you know, more people concerned with bringing all these different services together. That it's not just about healthcare; it's about social determinants of health. It's about people's housing. It's about their harm reduction. So you know, and those are all great things. So you know, I missed most of the COVID pandemic. I wasn't working during that period, so and I can't tell you how grateful I am to my creator that I was spared that, because I know a lot of effort and a lot of work went into it, and I really am grateful for those that were working and did do that. One of the questions I wanted to ask, well, again, I think one of the best things we learned was just what everyone, Steve has talked about, how everyone can get together and do this. How, you know, it didn't matter whether a client needed, you know, doctors realized that my client not only needs my health care, my physician's care, but he needs, or she needs, harm reduction, access to, you know, safe housing and shelter, and all those things had to come together, and it was great that did. So my question now is, do you see that continuing? I know things have kind of regressed a little bit, you know, they've gone back to the kind of way they were. And more importantly, well, what I'm kind of interested in is, what happens now if you present with COVID symptoms and you're homeless and you need quarantine or you need services? What's the process now? I'm really not familiar. I remember there were tons of, you know, trailers and testing and quarantine sites, you know, the Sobering Center over on Maple, all those places, Heidi. So, you know, what is the process now?
Yeah, good question. I'll take the last part of your question first. So actually, we just went and saw someone who tested COVID positive in a shelter this morning. And, you know, COVID has really changed in the sense of, like, before it was a type of virus, probably because as a people, we weren't used to it. It was causing a lot of sickness and landing people in the hospital and very sort of like rapidly spread. And what was dangerous about it was that if someone got sick, their risk of getting really sick and being hospitalized was high. And that's changed, thank goodness, because we have vaccinations, more of us are used to having been exposed to COVID, so the risk is not as high. So right now, actually, there are new guidelines that say if you're COVID positive and you're not symptomatic, you actually don't need to isolate, right? And so when we went and saw the gentleman today, he was fine. He felt good. There was like an outbreak in his shelter, but everybody looked good, had been vaccinated. We were like, do you want another vaccine? Sure. You know, and so he was able to stay where he is, right? If he was really sick, right, then we would figure out how to take care of him, which would probably be like to move him, if the shelter wasn't able to isolate him, to move him somewhere else. And we do still have places that we can do that, which is good. It doesn't have to be at the extent, thank goodness, that we had before, just because there are not that many people who are getting ill. But there's not also as much testing going on, right? So it's possible that there are 3 people in this room are COVID positive now. We don't know, but again, because everything is sort of quieted down, it's not as scary as it was in terms of people getting really sick. But those resources are still available. I think with regards to your question about like, have we regressed? I don't think we've regressed. I think like the spirit is still there and I see things building, like Steve's talking about in terms of like the investment of dollars in building the proper site. Like, and I think that's coming at the heels of what we experienced, which is we can do this, like if there's committed funding. Tons of money now coming from the state with the mental health substance use dollars that like DMH for the first time is like, we're gonna send 170 staff into shelters to provide direct mental health care to people who need it. That wasn't done before, right? SAPC, the substance use prevention and control people, are actually starting field-based treatment. They're saying it's not just enough to say, if you want treatment, you have to come to Tarzana Treatment Center and be admitted. They're like, okay, that doesn't work. You're like, no duh. Like, they're like gonna send people out. Now we have to push them. This is somebody questioning. Yeah, like who are the people who are pushing that button to make that like that promise is delivered on and those field-based services are appropriate and dignified and effective? We're having those conversations. It's being funded now in ways that it wasn't before. We're doing more integrated care now through PSH. Like not only do we have like the ICMS, but more and more we're getting the DMH mental health caseworkers and the substance use caseworkers coming together to provide multidisciplinary care to people who need it in permanent supportive housing. So there's a lot that's happening, which is really, really great. Is it at the level we need? No. And that's dependent, again, on funding and political will, right? So like your vote on Measure H is critical, right? Like you've probably, and again, I can't endorse anything, so I should. Your vote as a person around like these measures, money, like saying like, no, this is what this place should look like. We should pay attention to the fact, like Steve and Lee were talking about, like the gaps, right? And one of the things that we found is like people who are African American, we're actually housing them pretty well through Housing for Health, but they're at highest risk of losing their apartment.
Housing retention, yeah.
And then the question is, well, what is that, right? So it's not necessarily getting into housing, it's like, why are they having trouble retaining the housing? And again, for me, it begs a question of what different type of services do they need to support them in that housing unit? Are they facing that same prejudice in their housing unit? Is it harder for them to integrate because of, so we can get into that. So those are the kinds of things that I think we're really pushing in, and we have to keep, and I think I want to encourage all of you to keep provoking us, right? That's important. Like, we don't have the pandemic provoking us, but like we need people to provoke us in doing things better, right? And being more accountable.
Thank you.
I'm Donato. I'm a homeless advocate, and I work in a lot of different organizations, and I've given kudos to each one of you many times for what you did with that intimate one-on-one, which we don't have here in Skid Row. Each person I have gone to that was a case manager had 100 people that they were working with. Why you were so successful was that intimacy of taking somebody from a horrendous place with sickness to finding a way to get well with inside, to restoring their dignity, to help them get housing, then to help them in that housing with transforming their life to be better and helping them find ways that they can explore to do different things and open new doors. We don't have that, and that to me is the problem. We get people off the street into housing, but like Lee said, they lose their housing because then you just drop it on the floor. Now they have all their friends are on the street. They want to bring them in and show them the house and have their drug parties so they get kicked out. There's nobody helping with the interim. There's nobody showing them that we have to make exceptions when somebody finally gets their key. They're going to want to bring people in. They're going to want to do drugs, just like you had to do when you were trying to get them to adhere to the COVID medications. You had to give them their drugs. You had to work with them. You had to then give them methanol. We don't have that here. And so it's so hard with the blacks that I work with in the community. I don't want to, they're the ones that lose their housing first because they haven't had that, the strength to be able to adhere to what they need to do because they haven't done it before. And so you're expecting them to do something that they don't know how to do. You're not training them. There's no interim. So to me, we need money so we have every case manager should have only 10 clients. Every person that I'm on my 10th manager in my place within just 2 years. And she's only working Tuesdays and Fridays and 4 hours a day. We have no security door.
And I think you're right, Iron, and I think one of the things is like, God, I'd love to hire 50 of you, right? Like, that's the other thing for me.
There's no accountability with the money too, yeah.
Right, but it's also making sure that we're hiring people who know that.
Yes.
And are able to relate to people, have compassion, create low barrier, have those real conversations, and walk with people from an informed, like non-judgmental space to be like, hey, I've been there, you could go this path, but here's another path and let me walk with you. And one of the things that happens now is with the case managers, some of them have lived experiences, some of them don't. They're overwhelmed.
Yeah. Way overwhelmed.
If they manage to stick a flyer under your door once a month, that's lucky. And like you said, that intimacy and that ability to make that connection is really critical, which relies on more people, like with your experience, getting out there. And we need funding to do that. We need political will to do that. And I think that is something that we need to keep organizing. Right?
That's where the money has to come from.
You're right. You're right. And we have to pay a living wage. We have to create those opportunities. And I think for me, like, we've been pushing and pushing and pushing to get, just a 15% pay increase for ICMS.
Yes.
Right? To make sure that we have that pipeline so people like you can become an ICMS and promote up. And those are things that we have to keep pushing for. because I think it's a very good.
Yeah, because, you know, the burnt out is there, but you guys still have the compassion to push through and to work with your clients and to have
So
that.
sorry to jump in, thank you.
Yeah, that's it. I just love that.
So Angie here has to catch the flight.
Oh, no, that's why she's jumping in her seat up and down.
Andrea, do you want to ask your question?
I have one very simple question. Maybe you can say in 2 minutes.
Okay.
How do you build a team? That's what you learned, that's what you said.
How do I build a team?
Yeah.
That's a good question. I don't know. You know, actually, I think you just have to like talk to people and sort of try to see what motivates them.
Yeah.
And to look at their strengths and understand that everybody has different weaknesses and try to set people up for success. So if you know that somebody has a hard time with this, but they do great at that, and you have this job needs to be done, you show them how to do it this way. And sometimes people will automatically go that way that they're not very good at. I'm famous for that. So that happens. But you just have to show them, go this way, because if you go this way, you're going to be successful. And then if they really, really want to go that way, you got to figure out a way to help them go that way and be successful.
Right.
So it's a lot about paying attention to people's personalities, people's
Finding their strengths.
needs, and finding their strengths. Yeah.
Thank you.
Thank you.
Only other thing I would just say is like I think Angie does have strength in working with individuals, but she also has strength in terms of like making sure that everyone is like mission oriented. Like when it's splintered, it's like we're all in this together, trying to get to this point. Can we agree to disagree because we all agree we need to get there?
That's very
and that's really important. Yeah.
That's a conversation I've had many times.
Yeah.
That's really, really important.
Because teamwork is very important.
We're gonna allow.
Okay.
He's gonna go fly away, everybody! Let's hear it for Angie!
Nobody moved us yet.
Oh, no worries, thank you.
Thank you all very much.
Much love. Safe flight.
Thank you so much.
Do you have time? Sure. One person who has been for a while. So we're landing, we're coming to our close, but I did want to honor, there was one more hand that I saw from a while ago, so would you like to, speak and then we can.
I'll just make this very brief.
Yeah.
Thank you so much. Thank you.
I want you to have the record back and speak. Y'all have laid out quite well how, from a very bird's eye view, what we're dealing with is not a subset of a broken economic system that is itself broken, and housing, I think we can all agree, should not be a commodity that is bought and sold in a market. It should be something that people have a right to.
Just like healthcare and education.
And that, healthcare, education, clean air, clean water, food. What you didn't touch upon, what I do for a living, I do street outreach for a living. I am that person who has the boots on the ground. I am that person who is in HLIS every day. And I just wanted to add that not only is the economic system and the system of housing broken, the system that is cobbled together out of government and nonprofit entities in Los Angeles County is itself a very broken system, very broken. I know because I'm working it every day. And I don't know, that's all I had. I could explicate that for you further if you want.
Yeah, I mean, I'd love to be part of the panel to explore that more, because I'd love to get
very low level, nuts and bolts level.
I'd love to get educated about that, right? Because it's important for us to understand that, right? If we want to build something
It's like
better.
all these great policies will not have an effect if the lowest level, nuts and bolts, cobbled together system is broken, which it is.
I remember it reminds me of something that someone said is like, it's sort of like the analogy of you have a puzzle box, it's a 1,000-piece puzzle, and you have this beautiful picture on the front, but then you open the box and the pieces are all a jumble. right? It's like everyone knows where you need to go, but it's like, how do you get all the pieces together is really hard. And it is a struggle, but sometimes I think, like you're saying, the vision is messed up to begin with, like what's on that puzzle box, but then also like we have pieces that are missing, pieces that don't fit well, and so many people holding different pieces of the puzzle, vying to fit them together, and it just doesn't work, right? So what do we do?
The puzzle will not ever work. Okay, it doesn't matter how great the puzzle is. You know, the overarching vision is at the extremely micro worm's eye level that I work on. It is definitely broken.
Yeah.
I sponsor.
Oh, I'm sorry. No, that feels sad.
But thank you for showing up every day and being in HMIS.
Yeah, I'm in HMIS every goddamn day. It's I'm at homeless encampments and looking people up in HMIS, typing crap in HMIS. I have one person who I looked his entire history up in HIMS, and it almost made me cry. Okay, like 15 or 16 case managers one time, and poof, they disappear.
Yeah,
and this person, I go to this person, I ask him if he wants permanent supportive housing. His answer is, I don't know.
Yeah.
And the reason why he says, I don't know, is because he's been let down 15, 16, 18 times by 15, 16, 18 goddamn case managers, people like me who didn't come back.
Yep.
Didn't follow. I'm sorry for getting mad.
No, it's all right. I second that. It's happened to me over and over again.
ICMS, the most highly developed skill that an ICMS case manager has is disappearing.
Really fast.
Yeah, real fast.
Yeah.
You wouldn't believe how fast it is. I have to do a warm handoff to an ICMS case manager, and I cringe every time I do that. I go, oh, Jesus, oh, what's gonna happen?
I have to go to 4 different hotels just to get my recertification because there's never a manager or a case manager that you can
They
get.
just disappear.
So everyone, we can continue some of the
I'm sorry.
connecting and
No, it's just something we need to do.
It's very valid.
Yeah, and there's some time for folks to connect and discuss maybe one-on-one and stuff, but I do want to allow, Steve, we lost me.
We lost Steve, we lost Angie. They're all disappearing. Talk about case managers going. Our panel is going. We're losing our panel just as fast as we're losing our case managers.
So we want to just end, perhaps, Heidi, would you just close us out with anything you would like us to really, like, last words?
Yeah, I want to hold what you're saying, which is like, it is frustrating, it's sad, it's heartbreaking, and what I'm going to say is thank you for still being in the fight.
Yes.
Yeah.
Thank you for still active witnessing. Thank you for not turning this into poverty porn. Thank you for like walking the walk and showing how it's supposed to be done, because we've got to make it better. We don't have a choice.